We're going to go over how to place a Combitube correctly in a patient. So the first thing you want to do is put on your BSI, body substance isolation precautions, your gloves. We've determined that this person needs a Combitube. He is unconscious, unresponsive. He has no gag reflex. You can check this by running your finger across his eyelashes. If they do not flutter, then he has no gag reflex. You want to open the airway. If you do not suspect trauma, you can do a head tilt, chin lift to open the airway. If you do suspect trauma, you do not want to manipulate the neck, so you want to do a jaw thrust and open it that way. Then you want to take an OPA and insert it. And then you want to pre-oxygenate your patient with 100% oxygen. So you're going to take a BVM with 10 to 15 liters per minute of oxygen. And pre-oxygenate your patient for 2 minutes before placing your Combitube. And I'm going to have my partner take this over. Where I prepare my Combitube. So I have determined that my patient is between 4 and 6 feet, which means that I'm going to use the small adult Combitube, which comes in the green package. If my patient were between 6 feet and 6'7", I would use the blue Combitube, the large adult Combitube. So I'm going to check my Combitube. I've taken it out of the package. I'm going to start with the blue side. And because this is the small adult, we're going to use 85 cc's of air for the blue side. So you're going to fill it with air, checking for leaks, and then you also want to make sure that your balloon is squishy. And then take the air out once you've checked it for leaks. And then I'm going to reset my syringe at the 85 cc's so it's ready to go. And then I'm going to go to the white one and put 12 cc's of air in it. And once again, check for leaks and make sure that my balloon is squishy. And then take all of the air out again. And then I'm going to preset my syringe for the 12 cc's. I will then lubricate the tip of my Combitube. At this point, my partner has oxygenated for 2 minutes. I'm going to direct her to remove the OPA.
Removing it anatomically?
We're going to have the patient's head in an inline position. And as we put the Combitube in, we're going to do a tongue jaw lift. And insert the Combitube until the teeth are right between the 2 black lines. So now I'm going to have my partner just a second, I'm going to fill my air balloons. Start with the blue one again, number 1 tube, with 85 cc's. And then the white one, the number 2 tube, with 12 cc's. I'm then going to have my partner hook up to the number 1 tube, the blue tube, the esophageal tube, to see if I have esophageal placement, which is the preferred placement of a Combitube. And we are going to hold on to that because it is not secure yet. And I'm first going to listen to epigastric sounds to see if there's anything coming to the stomach. And I hear no epigastric sounds. I will then listen to lung sounds. And if I hear equal lung sounds on both sides and see adequate chest rise, then I know that my placement is in the esophagus, in the blue one. If it is not, if I'm hearing just epigastric sounds and no lung sounds, then I'm going to suspect that it's a tracheal placement and I need to switch to the white tube. If that were the case, I would have my partner switch to the white tube instead of the blue tube. And I would re-listen for lung sounds starting in at the epigastric. And if I heard no epigastric sound, and equal lung sounds with chest rise, then I would know that I had tracheal placement. And if that were the case, I would then secure it in the tracheal placement using an OPA for a bite block. And then taking tape to secure it to my patient. And then you want to constantly reassess to make sure that you had placement of the Combitube.